Hi guys, we are going to talk about therapies and the nurse's role or what the psych nurse does. Therapies, you might see a patient tell you, I have tried ECT and we're kind of wondering what this is. So we'll go into that a little bit more. There we go. So our objectives today are going to be, we're going to explore some various illnesses used to treat mental illnesses. We're going to define the role of the nurse in the mental health setting, which is what you guys will be when you are going to Lord's Counseling Center. And we're going to enhance that knowledge of the therapeutic relationship, which was talked about, discussed in your freshman theory class. We're going to gain some confidence within that nurse's role. So let's go into some of the therapies, and we'll talk about 4 different kinds of psychotherapies that you might be seeing. Involves a therapist, so we're not psychotherapists, nor do we claim to be, but we do need to know all of the therapies that a patient might be undergoing. Uses a range of techniques to help a patient overcome troubles and gain insight, achieve some personal growth there. So when we go into the psychodynamic type of psychotherapy, I want you guys to think Freud, like the person on the couch, and the therapist is using like dream imagery and free associations to explore these deep-rooted, impactful childhood experiences that might be the cause of why a patient is doing what they're doing. And at the end of this, it's not really very useful because it just says, well, you're have this issue because blah, blah, blah. But it doesn't explore kind of where a patient can go from there. But I guess sometimes explanations of why we are the way we are is a little bit helpful. It's just not that commonly used anymore. We use a lot of this existential and humanistic type psychotherapy. This is the belief that people have an inherent capacity for making rational choices, achieving self-acceptance, and attaining the maximum potential. And it promotes growth through client-centered approach, empathy, genuineness, acceptance, and active listening. So by doing all of this nice therapeutic relationship with the patient, they're going to go ahead and explore not only why they are the way they are, or why they're doing the things that they're doing, but it helps them gain that confidence to grow. And then we have behavioral, and this stems from the thought that the behavior is the issue. So they're going to take care of the behavior, and then the fear or the problem will take care of itself. So this can be seen in the way of exposure type therapy. So this is facing our fears head on. For instance, if somebody has a fear of public speaking, the therapist might coach them a little bit and say, okay, let's go do some public speaking. You're set to go October 12th. And then we have the much more calm systemic desensitization. This is where somebody is like slowly introducing that fear until it's become desensitized. And what happens with that is a person with a fear of public speaking might join a group of individuals along with their therapist who is also afraid of public speaking, and then they do all these little practice sessions, and then they where they will start speaking in front of their cat, and then they'll speak in front of a small group, and then slowly build up to that larger group, and pretty soon they're public speakers. Then we have our cognitive psychotherapy, and this focuses on rationalization. So the thought process here is that if we could change the way that we think and what we're saying to ourselves, then we could change the way that we feel and operate. And along with this one are something called cognitive distortions. So people can do all sorts of things. They can be like all or nothing thinkers. Either this is totally right or totally wrong instead of recognizing those gray areas. Or they can be a labeling type person, or a person that labels, I should say, where they're just saying, "Oh, I'm such a loser. This is stupid. I'm dumb." Things like that. But they will also do like this magnification or catastrophizing, they call it, where they think of the worst thing possible instead of kind of the probable of outcome of things. Personalization they'll use, jumping to conclusions. So in the way of cognitive therapy, the psychotherapist is helping them recognize these cognitive distortions and then change the way that their thinking pattern there. So there's a little bit of therapy there that you might see. Then we have biotherapy. Obviously, our most common is going to be our medications or psychopharmacology there. And we're going to be going heavy into medications. You're going to get it from like a million different angles, and you just need to know this stuff because psychotherapy medication can go, or psych medication, I guess, can go bad real quick. So we have to know this stuff. You might also hear a patient talk about electroconvulsive therapy or ECT, like I was just talking about, and this is still in use today. It's just actually just not as terrible as it looks. And what happens is the patient is placed in like an outpatient procedure type setting where they'll have somebody that will sedate them, and after they're sedated, then they initiate a seizure. And what happens with this oftentimes is that it will alter neurotransmitters that modify all these stress hormones and kind of reset you, which is kind of really interesting. That seizure lasts a couple of minutes, and then it's done. People usually have to go through quite a few sessions of this, or intermittent sessions. Then we have the transcranial or deep brain stimulation. There's not a whole lot of clear explanation on the mechanism of action of that, but it is also thought to alter those neurotransmitters or kind of reset our hormones, just like that electroconvulsive therapy does. The thing that you'll be seeing in the counseling center is what's known as milieu therapy, and this is defined as a scientific structuring of the environment in order to affect behavioral change and to improve the psychological health and functioning of the individual. And famous psychologist Dr. Skinner had kind of created this milieu therapy. Recognizes the nurse as, oh, look at us, we're a member of a large community serving the patient. So lots of community members there, which is what we'll see at LCC. The community includes psychiatrists, case managers, clinical psychologists, a psychiatric nurse, that's us, mental health technicians, which is kind of like, I would call it, these guys like the CNA of the mental health world, social workers, occupational therapists, recreational therapists, music therapists, art therapists, dietitians, and chaplains. And you'll see a majority of these at LCC being used. They also might do a little bit of group therapy while they are in this milieu therapy to have this sense of community. While they are not on the inpatient unit, they might also be using some group therapy. Group therapy benefits an individual by enhancing all of these things that make us feel close and connected to society and our communities, right? And that empowers us. We can form friendships and create these camaraderies. We can do some information sharing. I learned how to do this. So all can be some positive things there. Then we have family therapy, and family our family group is viewed as a system where one behavior influences the whole system. So each member within the family is considered when they do family therapy, and kind of speaks for itself, but recognizing that we're an important member of our family. So, what's a psychiatric nurse? A psychiatric nurse is one who provides ongoing assessment of client condition. So, we need to be aware of what's going on with assessment, both mentally and physically. So, we haven't lost our total nurse brains as far as anatomy and physiology are concerned, disease processes. The nurse will manage the therapeutic milieu on a 24-hour basis while they're at an inpatient unit like LCC. And they administer medication. They assist patients with all therapeutic activities as required. And the focus is on a one-to-one relationship development. So within all of this management that the nurse is doing, they're also developing these one-on-one ties with the patient. So they can build trust, gain information, and figure out how to best help that patient. Does this all sound familiar? Well, yeah, it's a lot like being an acute care nurse, right? But in many ways it's different. We can go explore those further. So the psychiatric nurse. The American Nurse Association gives nurses further responsibilities in this cause. They are to coordinate the care, understanding which each role does and coordinates. So they need to be in charge of all of the goings on of the inpatient unit. They need to do health teaching and health promoting. So employ strategies to promote health and safe environments for these patients. Obviously, they're going to do pharmacological, biological, and integrative therapies, and it integrates a knowledge of these three things with applied clinical skills to restore health and prevent further disability. During milieu therapy, the psychiatric nurse provides structures and maintains a safe, therapeutic, recovery-oriented environment in collaboration with patient families and other healthcare clinicians. And in that therapeutic relationship where they're one-on-one in counseling, they're going to do some basic psychoeducation skills and problem discussion interventions. So use a lot of our therapeutic communication that has been hopefully suffered into you guys by now. So there are two areas that the psychiatric nurse is particularly adept at, and this is enhancing therapy by way of utilizing a recovery model, and then they're going to develop that therapeutic relationship with the patient. So I don't know if you've noticed, but that therapeutic relationship is important. And the more genuine we are, the more apt a person is to be able to tell us their stories. So I want to talk a little bit about recovery model. It's defined as a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach all their full potential. The nurse enables facilitation of the patient's self-directed path. And one of the more famous recovery models that we use is called the Wellness Recovery Action Plan, or the WRAP plan. And they use this a lot in transitions. In fact, it's pretty cool. You can actually download an app and realize or create a WRAP for yourself. It's kind of interesting. So the WRAP, the person develops this wellness toolbox. So basically they've created these plans should things kind of progress to a level where they are unable to take care of themselves. So they need to figure out what tools relieve disturbing symptoms. Are they going to use guided imagery, running, music, venting, taking a walk in the woods, what have you. And then they do this daily maintenance checklist. So this is a checklist of things that need to be done every day, and then steps by getting them done. So their goal might be to eat 3 healthy meals a day. And how are we going to get this done? I've created a grocery list, this type of thing, daily maintenance list. And then they need to recognize within themselves their own triggers. Sometimes, more often than not, seems to be drug-related type triggers, as methamphetamine or even marijuana can trigger these patients into declining, and then they develop a plan for when these triggers occur. Then we see early warning sign, or the patient is able to develop these cues for recognizing these early warning signs. These are going to be like subtle cues, and then they develop a plan for when that occurs. Then they are going to, in step number 5, it's called things are getting worse, or breaking down. And this is where they identify symptoms and then develop specific strategies for when things are on the decline there, such as calling family members and letting them know, or remembering to take medication. And then we have crisis planning. This is developing a strategy for others. So at this point, the patient is no longer able to take care of themselves. They have developed a strategy, however, for others when they're unable to do this. And this could be giving someone the gift of telling them, sometimes I go into a psychosis, and if this happens, I am not responsible for my actions, but I need to be going to the hospital because I am unable to care for myself. And these are the symptoms that I will have. And even though I may decline or fight you on this matter, we've already established that I have given you permission to help me out in these situations. So if you want, you could check out that RAP app. It's kind of interesting, like I said. So therapeutic communication, I know you guys have gone over this quite a bit in your freshman year, but basically this is a relationship formed to meet a goal. So therapeutic use of self is the ability to use one's personality consciously and in full awareness in an attempt to establish relatedness and to structure nursing interventions. So you guys might have found out yourselves how you can really mesh with certain patients and really not well with others, but you have to develop these strategies for Sorry about that, guys. Brief intermission. You never know what's going to happen when you're in the office here. In my case, I just had to rearrange my desks. So let's go on with the therapeutic relationship. Obviously, by now we should be aware of what this is. This is where we're going to use our self there. So just like I was talking about, we have obviously better relationships with some over others, and by the end of this, I hope that you guys have a few more tools to get in your toolbox to get through to those patients that kind of need you the most but might be the hardest. Okay, some essential components of the therapeutic relationship are your ability to establish that rapport, and sometimes it could be a little tricky, but I have faith in you all. And then establish a trusting relationship. that's built on respect, genuineness, and empathy. And as you guys have probably learned from last year, empathy is not also having the arrow in the bottom, but the concern for the patient that has the arrow in the bottom. So during the therapeutic community or relationship, you're going to be going through some phases. During that pre-interaction phase, you're going to go ahead and do your research if you can on the patient, and then you have to kind of check yourself at the door, like I had talked about the last lecture. How are my preconceptions getting in the way of potentially being able to care for this patient? During that orientation phase, you're going to be acquainted with one another. We're gathering assessment information. We're identifying potential barriers to that therapeutic relationship. We're going to be formulating our nursing diagnoses, and we're going to be setting goals with the patient, not for the patient, but with the patient. With that, we're going to develop that action plan. So put our assessment, diagnosis, plan, intervention, evaluation into work there, and then we're going to explore feelings of both the patient and the nurse. During that working phase, the patient is gaining insight into their reality, and you are gaining insight into the patient's reality. You guys are going to be problem solving together, and sometimes anxiety levels rise along as patients uncover issues. You will recognize that. You will overcome resistance behaviors. So the patient might kind of want to break down and quit this therapeutic relationship, but we just continue on. And then we're going to evaluate the progress towards the goal attainment. How are things going in that working relationship? Then when we're done, we have this termination phase, and the progress has been made to mutually agreed goals. You're going to form a plan for follow-up or resources that you will give the patient, and then you're going to discuss feelings about the termination. Here's those big words are transference and countertransference that you guys have gone over in your freshman class. And transference is when the patient unconsciously displaces or transfers to the nurse's feelings formed toward another person for his or her past. So lucky me when patients have good associations with blondes, something I might have to overcome when a patient has a negative association with blondes. This is the type of transference that happens. And then countertransference is the nurse's behavior and our emotional response to the patient. And this is from our own past. Recognize that both exist. So we have potential boundaries that might interfere with a good solid working relationship. One of those might be a material such as a computer, a physical structure there. Sorry, I'm in my computer, I'm not listening to what you're saying. Oh, technology. So sometimes it's a computer. Then we have social boundaries like cultural expectations. We have personal boundaries. This is boundaries that the patient has established for his or herself. And those might be physical or emotional, such as a person that has a lot of fears related to COVID-19. They might not want a person that's 10 foot from them, and we know that about 3 feet is a good space generally for this therapeutic communication or therapeutic relationship. So the patient might themselves put boundaries on there. Then we have our professional boundaries, and these are boundaries that can lessen the benefit of care on a professional level. Speaking of professional boundaries, this is where we generally fall down for the patient. 4 of these. So one is self-disclosure. We're talking way too much about ourselves, and it's personal and it's inappropriate, and it doesn't have anything to do with the patient getting better. We might be doing this for our own therapy. Sometimes it's good to give an example. So like when we're establishing a relationship with the kid, someone in their youth, we do share a little bit of information about ourselves, and then they realize that they can become reciprocal. So a little bit of information sharing is okay if it's pertinent to the experience. Then we have gift giving. We should not be receiving gifts from the patients nor giving them large gifts. Touch is a professional boundary. Oftentimes when we're not doing psych nursing, we do a lot of kind of touch therapy. All my students have noticed that I touch my patients a lot, give them little hand massages and things like that. But obviously we're assessing the situation as it comes and making sure that we're not breaching that boundary for them. And then if you've had a prior friendship or a romantic association with that patient, obviously you can see how that could be a hurdle for that therapeutic relationship. Solar approach, this is something that may or may not be on your quiz. You always identify like, oh, if it's this, this, and this, I should know this, right? That's what I do in my own quizzes. So we'll sit squarely facing the patient. O, observe and open posture. So our legs and our arms are going to be uncrossed. Our hands might be kind of open or so the patient can see them. We're in a relaxed position, but leaning towards that patient because we are interested in what they have to say, but everything's a little bit kind of more subdued and relaxed oftentimes. E, we're going to establish that eye contact, noting that some people don't appreciate that eye contact. So it may not be something that we always do, but eye contact is generally a good thing. And then R, relax. We're going to communicate that sense of being relaxed. So attentive and relaxed. I'm here to listen to you, right? Okay. So as for techniques, I know this is like beating a dead horse because you guys went into those extensively, but it is highly encouraged that you become acquainted with your table 5-3 and table 5-4 within your book. And it talks about therapeutic communication techniques and then non-therapeutic communication techniques. And I won't discuss that any further, but we're done for this lecture. Thank you.